I'm going to speak about Denmark, and I'm not a hepatologist, I'm an infectious disease physician, so if I do any sort of damage to hepatology, please excuse me, I don't know any better. And these are my disclosures. So, as we heard earlier today, we have this elimination targets from the WHO, but what is worth noticing is that the real elimination targets of incidence and prevalence is not really what most people operate by, mainly because very few countries actually have these data. So the majority of countries, including Denmark, operate with having 90% diagnosed and 80% of eligible treated, and 300 needle and syringes per people who inject drugs per year. But what's also in the WHO strategy is the importance of interventions for impact, delivery for equity, and financing for sustainability. And some of my talk will include this as well. So, Denmark, it's a small country, 5.8 million. It's probably smaller than Paris. We do have some things in Denmark that works for us with regards to elimination. We have a national single-payer health system. Since November 2018, as I think the last country in sort of Western Europe, we had access to treatment for all. We've got free testing and care. We've got some patient registries. They're not perfect, but they're better than most places. We've got some reasonable good regional data on prevalence of hepatitis C among people who inject drugs. And we do have harm reduction for people who inject drugs. But there's also a lot of things we don't have. We don't have a national plan or strategy. We have absolutely no national funding for elimination initiatives. Specialists cannot prescribe. We have no incidence. We have no mortality data. We have not yet updated our national prevalence data. We don't know how well we're doing on harm reduction coverage. And we don't have a strong patient advocacy voice. So I think we've got some good things, but we also have a lot of things that we don't have. In 2010, when the DAAs were sort of almost getting there, David Thomas made this excellent comment or editorial in The Lancet that he said, the next 10 years will be all about access. Now we've got something that works for the individual, but if we don't do something about access, we won't get anywhere. And I don't think that he sort of even imagined that he would be as right as he actually turned out to be. So what about Denmark? We've got sort of a one-humped camel. We have a fairly old epidemic. Most people were infected by drug use, and most people, as intravenous drug use among young people in Denmark is not that common, is actually becoming of age, and my usual patient is definitely somewhere between 45 and 65. We do have healthcare-related infections, but they are getting quite old. So that gives us a diagnosed prevalence of not that much, 0.3%. In the older population, it's quite low. We just tried to update our estimate of prevalence, and we think we might have somewhere between 10 and 15,000 cases, which says something about how uncertain we actually are about how many people we've diagnosed. So where I come from is the region of southern Denmark. Denmark's got 5 health regions. They each have sort of their own budget, their own way of doing things. And in our 1.2 million region, we've worked for a long time about getting hepatitis C testing and treatment out into drug treatment centers. And this has been an advantage for us because we did have some experience when we, a little more than a year ago, actually could treat everyone. And we also had some reasonable prevalence data, and we knew that about 1 in 3 of people who injected drugs that attended a treatment service at some time had hepatitis C. So some years ago, we made a plan and say, well, if we look at all the populations we have, not just the people who inject drugs, not just those who are in the outpatient clinic, not just the diagnosed, but we look at all the populations we have, how do we think that will look, and what can we do about it? So basically, we've tried to develop a micro-elimination strategy for each of these populations, and then hope to achieve macro-elimination by targeting each and every one of them. And I'm not going to spend a lot of time on it, but of course, all these patients we have in our outpatient clinic, since we have now access for treatment, we can just treat them. That's about 1/4 of the patients. Then there's another 1/4 of the patients that are diagnosed. We know them. They've been at a hospital registry or lab registry, but they dropped out or they were never in. And for those, we have a callback and treat strategy. Unfortunately, we can only, due to legislations, call in those who've been with us at least once. So those we've contacted. And even though it's not that many patients, we haven't had anyone yet saying, I'm so sorry you called us. They're all really happy that we did not forget them, and that we wrote them a nice letter and say, well, once you've been with us, please come back, we can treat you, and that worked well. But call in those we only have at the hospital registry, only on a laboratory registry, so we've never seen them, but we know they're hepatitis C RNA positives. Due to legislations, we can't contact these patients, but we're working on it, but it does require some government work and new legislation. Then there are the undiagnosed, connected to drug treatment centers. They're not that hard to diagnose because we know they're there, so we just need to get the test out and treat immediately after testing. And then there are the undiagnosed with no connection to drug treatment centers, so we don't have a sort of a good connection. And for those, we've had to design a few more interventions, and including starting up a mobile service, driving around the entire health region and trying to find people in shelters and where people gather, safe injection rooms. And we're also setting up screening programs in emergency medical services and psychiatry services. And then we've tried to get some media attention because hepatitis C is really not a very known disease in Denmark. So, but what matters if you really want to achieve elimination? You've seen this slide before. It's about the incident population. It's about those who transmit. It's a really important target. And in Denmark, we recently it was part of a modeling paper by Tricky that found that 92% of our new cases were due to injecting drug use. In France, it's 93%, but if you go to sub-Saharan Africa, it's of course a different case because you've got much more healthcare-related transmission. And as Ola also said, and many others have said, it's about finding those who transmit. And I've been treating people in drug use, active injectors, for about 5 years. And when we treated without having access to treatment for everyone, we had a lot of reinfection. And that's just the way it is. If you don't treat everyone, you will have a lot of reinfection if you're treating the incident population. Otherwise, you're treating the wrong people. And what I found is, now we're in France, so Cherche la Femme, I think it's called, that what we found was actually a lot of our clients got infected, maybe by the girlfriend at home, or that we didn't see, or because intimate partner sharing is much more frequent than sharing with some random guy on the street. If you share with your partner, you think it's safe. So we've seen a lot of reinfections between couples because we didn't know that they were injecting together, or they didn't think about it, or anyway, so always treat the partner. So what are the critical questions we want to ask ourselves if we really want to micro-eliminate in people who inject drugs? First of all, is there access to harm reduction and prevention? If you don't have that, you should start with that. And are the people who need to be tested actually tested? Do we only test those who always come to the clinic and put out their finger? Or do we actually test the right people? Do we test all the people? And can we actually engage them in treatment? So these three questions are really important, that when you start looking at an injecting population, that you have good answers for these. So let's start with prevention. We know prevention works, and prevention is clean, not just needles, but also syringes, water, filter, whatever goes with injection. And it's OST, that should be a low threshold. You shouldn't have to be abstinent for half a year to get into an OST program, or be kicked out if you're not there for one day or have a positive urine screen test. It has to be a real offer. And that was one of the surprises when I looked at the Denmark case, and I thought, well, Denmark will do great. We did terribly, especially in needle and syringe provisions. In half the places in Denmark, there wasn't really any offer, and there was only 1 out of 97 centers that in 2017 used international best recommendations. This has improved, or improving over this year, because there has been an intervention. But it's really critical that we also support harm reduction as part of an hepatitis C intervention, or we will waste our time. And how can we see that we will waste our time? Now I'm going to pull out Sweden. I'm sorry, Ola, but we did some modeling some years ago where we looked at different countries that had different levels of harm reduction and different prevalences, and see what can we achieve if we treat a certain number with the same number for all these cases. And in the case of Denmark or Slovenia and Norway, we could actually, by treating not that many people a year, eliminate. And what was the difference was the access to harm reduction. Whereas a very high prevalence country from like Sweden, with not a widespread coverage of harm reduction, could treat as many as they want. They would never achieve elimination. But that has made Sweden change a lot of things. So it's been a good thing that we had these data. So I'm going to show you some models of care for people who inject drugs. There's one in Copenhagen, but I'm not directly involved with, so I won't say any more about that. But I'm going to tell you about 2 models, one where I work and one in Copenhagen, where I'm involved in that as well. So the one that I'm involved mostly with is people who are on OST. And we did some data on these up to 2016. And what we found was actually, once you're on OST, you tend to sort of stay there. So 80% of those people who have ever been on our OST program was actually still there. They didn't go anywhere. They didn't get out of OST. They stayed. So they were a reasonably accessible population to treat. So we had this model, which was basically that nothing should happen at the hospital. Only if you had severe liver disease, needed an ultrasound or a specialist hepatologist for incompensated liver disease, you had to go to hospital. Otherwise, every single step of the cascade of care should happen at the drug treatment center. So basically, what we do is that the treatment center test. They can do that by venous testing or by dried blood spot, but both of them have to give an HCV RNA as a reflex of an anti-HCV positive, so you don't have that multiple steps in testing. And then we, as ID physician, simply move our clinic out maybe once a month or twice a week, or twice a month, to the OST centers and treat people there. And I would say it's a lot better to sit there than to sit in the office at the hospital waiting for people who never showed up. And we've reached a lot of people this way. And we just prescribe or bring actually the medication, and then they get it with the OST, or we've got 100 people on legal heroin. They come every day. They're the easiest to treat. And this dried blood spot testing, probably a lot of you are familiar with it, but it's really moved a lot of things for us, because you get hepatitis B, hepatitis C, and HIV in 5 blood drops. Everyone can do it. It takes about 2 minutes to learn. They can stay there for a week. So you have a lab that's interested in setting it up. You need to validate it because there's no commercial options for it, but it's really good option for having a lot of people be able to test and not be depending on fast delivery to a central lab. So basically, that's what we've done. We have looked at our region and say, where are the drug treatment centers? And then we have trained the people in the drug treatment centers to test and say, well, go out, test for a couple of months. When you've got your population tested, we'll treat everyone, and we'll come back later and see if everyone's cured. So we made sort of a plan and say, well, we can't be everywhere at once, so we have to make a plan and say, well, now you start testing, then we come, then we treat, and then we check if everything's all right. And do that sequentially, because we're not that many people. We are 4 doctors doing this, so it's not like we've got a huge setup. And these are the results for the first 4 months, where we managed to get 75% tested, 60% on treatment, and only 30% we had not seen yet for the first center. This was data of July, and data as of today is that of these drug and treatment centers around the region of southern Denmark, we've now eliminated in 2, meaning that we've tested 90% and treated 80%, and we've got 10 out of 15 centers now in the treatment phase. Only 1 has not started testing, and the 2 remaining centers are just testing and awaiting that we are coming for treatment. So in 11 months, I don't think actually we thought ourselves we would get this far, but what actually moved this was that the people out at the centers were so engaged in testing. We didn't actually have to do anything. We came, gave a talk, gave them a cards and say, just test, and everyone you find, we will treat. And then we try to make sort of a bit of fuss about it, because then the administrators are happy and the hospital director is happy. So every time we eliminate in a center, the professor, as some of you might know, Per Christensen, he comes with a special cake, and we have like a cake ceremony, and they get a diploma. Congratulations, you've now eliminated hepatitis C in your drug treatment center. And it's so important that even Air France wanted to put an ad on the website. So what have we learned about treating outside the hospital, treating in drug treatment centers, is actually that all the blood tests we started to take didn't make any difference, and they were rarely taken, and it took a lot of time to make people come and have a new blood test every 4 weeks or just after 2 weeks. So now we just stopped. So unless on the first blood test they've got cirrhosis and the fibroscan shows cirrhosis, we don't do any testing until they're up for their SVR12. Of course, they can be tested if they feel bad or there's a problem, but actually we don't do any routine testing on treatment anymore. But what about those who inject drugs who are not on OST? These are the undiagnosed, unfollowed, not in care people. And for these, we definitely have no good option in my region at the moment. But luckily, I've been involved in another project in Copenhagen, and we've learned from them. Because people who do not go onto OST, they don't stay. So only 6% of those we diagnosed with hepatitis C, but were not on OST, was still there. Otherwise, they just disappeared over the years. And this is the Test and Treat Copenhagen project. And this is actually initiated by drug users themselves, former, current, or somewhere in between, that applied for some money, got a van, started testing, and then they met Jeff, me, and some other people and said, shouldn't we also treat? And it's like, yeah, sure, we should treat. So what they do is they know where to park the car. They know where people go. They know what to say to get people tested. And they do. And once they find someone that's positive in the van, then they call the nurse and she says, well, come with this person and we can do everything in one day and then we can put people onto treatment. But the treatment is basically led by the peers themselves, by the patient organization. So they support patients, they take the medication for them, they tell them when to show up so that the amount of work for the healthcare system is actually quite small. And how have they done? Now I forgot the reference, but we presented this earlier, that of those patients they found, the first few months they did it, they got a little more than half through to treatment. And unfortunately, we discovered another problem was that we don't have enough of treatment to illegal migrants. And a large proportion of those that we diagnosed that we could not get onto treatment was because they did not have legal status in the country. And that's a problem that we still have to solve in Denmark to achieve elimination. And we also asked the patients themselves, the people who inject drugs, how do you feel about getting treated? Because that's an argument I've often heard talking to legislators and say, well, people can't feel the difference, they've got so many other problems, they don't care. But I can just tell you that they do. And in this survey, what they all said was, or the majority said, that they felt an improvement in their mental health. They saw the treatment, that they completed treatment as one of the not so often experienced successes, that they felt more energetic, more active. But they also expressed the fear about being infected again, and sadly, a lot of them, or a third of them, actually had no plans or no knowledge about, is my liver all right, or should I go for checkups? And that's definitely something we have to look at, about how do we look after those who actually got liver disease and not just an infection. So my take-home message is that we couldn't treat everyone until 11 months ago, or, oh no, sorry, 13 months ago. But we used that time for planning, and we started small and say we're only very few people, so we can't do a lot at one time. But we'll try to make a plan so we can do a little here, a little here, a little here. And then we have to find some people who can work for us for free. They don't have to get extra money, they just have to agree to do that testing bit. And that's absolutely essential. If you want to reach these populations of people who inject drugs, you have to cooperate with the people closest to them, the ones who know you, the ones that can tell you where the patient went if you can't find them. And that support in this population is a lot more important than blood tests. It's important that there is someone who can support people in taking their drugs, that they can go to and get an explanation if they've got side effects or feel nauseous or whatever. And only use the specialist for special cases. This is not a disease that in the majority of cases require neither an ID physician or a gastroenterologist or hepatologist, but of course we have to find those people who actually need a specialist. And just none of this would be possible without all these wonderful people around our region that helps us. And all they get is actually a T-shirt. Of course, they use some time, but the drug treatment centers are happy to give us with that time because it solves a problem for them. So that's all. Thank you very much.
Thank you, Anne, for sharing with us your experience. Thank you for this comprehensive lecture. And it's open for a discussion. So feel free to ask questions, to provide your own experience. Just ask any question you want. So if you have a young doctors in infectious disease, in hepatologists, and you have to give him advice about eliminating Hep C, what you have learned from your program, what are the most important advice you should give him? It's engagement, it's human support,
It's about following the patient. It's if you sit in your office and wait for the patient to come to you, you will be sadly disappointed. So you have to find out why they're not coming. And it might just be to know who to call if they're not coming, or how to get in contact, who's their contact person. Make a note, please call this street nurse if Jonas doesn't come. So it's little things like that. It's like it's about that's also part of our doctor responsibility, is also the patients we don't see. Yeah.
Sorry, Viktor Asar from Prague, Czech Republic. Please, because the prices in the Czech Republic for HCV treatment are still pretty high. My question, sorry for curious question, what is the price in Denmark nowadays? Because in Czech Republic it's 20,000 euro per treatment, and I know still one country which is the price pretty higher. It's Slovakia. It's 30,000 euro per treatment.
Yeah. Well, the prices are negotiated with the government, so they are secret-like, but they are somewhere between 2 and we don't use euros, so I have to count, 2,000 and 5,000 euros for a course of treatment. We'd have, unfortunately, still genotypic-specific treatment, so we have to do a genotype because that's the way the tender works, but it sounds like a lot cheaper than in Slovakia. But that was the main reason we could not treat until end 2018, was that no one would pay the prices we had before, which were at the same level.
In France, it might be like around 20,000 euros, but then there's also agreement for price volume. So I think that the price can be reduced, and so there's secondary official price, and then the final price might be different. Other questions? Mustafa, we know you love Denmark. So Mustafa Benazouz is from Rabat in Morocco, and he wants to ask you a question.
I see in the one slide that only 97 municipalities were involved in this program and 41 not. Why all those are not involved in your program?
The data there was, the municipalities have the responsibility of the OST and needle and syringe provision, and we only got 97 municipalities in Denmark. So that's the total number. But the data with the 41 was those who did not provide needle and syringes within their municipality. So they said you have to go to the next municipality, you can't get anything here. No, it's all in the municipalities who's got that responsibility, but how they choose to enforce it is different. But having this hepatitis C program has actually brought on that change that if we tell them, well, if you don't provide harm reduction, you will have reinfection. And that has made a lot of the centers and municipalities saying, at least in my region, well, we probably should do better because we can't afford to keep treating all these reinfections.